Greetings from Guwahati. I'm Dr. Jay Deep Ghosh, working in Apollo Hospitals, Guwahati. Today I'm going to present a case series with short early result about minimally invasive scoliosis surgery. So the problem is that conventional posterior scoliosis surgery correction is costly. They have a long duration for the surgery. They bleed a lot. They require massive blood transfusion. And they are performed preferably in tertiary care centers with a lot of precautions and equipment. And so it is less widely used. So our solution is that we try to explore minimally invasive scoliosis surgeries with our own modifications to reduce the cost with less sophisticated equipment support, and that leads to less morbidity and faster rehabilitation. Here we present a case series of 5 patients operated by minimally invasive scoliosis surgeries. So this is an example of a 13-year-old girl with neurofibromatosis, and the patient has a major lumbar curve of 82 degrees, apex at L2, compensatory thoracic curve at 36 degree. That is completely corrected on bending flames, and the planned fixation is from D4 to L4. So this is how we do it. We use 3 skin portals, one at the top of the fixation at D4, D5 level, one at the middle, the fixation at D2, L1 level, and one at the caudal end at L3 and L4, the planned fusion mass. The middle incision around L1 captures the apex of the lumbar curve. So what we do is that we do a midline exposure with bilateral subperiosteal dissection at each skin portal. We use a mix of freehand and C-arm guided technique for screw insertion. We use non-connected reduction pedicle screws for rod capture. So this is our modification for cost reduction. In literature, it is given that they use minimally invasive screws, but they are very costly. And with the elongated tulip of a reduction screw, it eases the rod capture. So 2 pre-contoured rods were slid cranially to caudally, and we don't do the opposite way, as the arrangement of the lamina is such that if we do it from caudally to cranially, there could be inadvertent entry of the rod into the thecal sac. So this is the C-arm view pictures, and then after the screws are inserted, we place 2 rods, use the simultaneous translation on 2 rods technique, and along with that primary technique, we use other secondary techniques like rod rotation, segmental compression and destruction, and in situ bending to achieve further correction. These rods were connected with 2 cross connectors, and then we can perform vertebral bony work like hemivertebral excision, Pontes osteotomy. That was not done in our case, but we use that portals for facet fusion. So I will talk about it later on. So fusion enhancement is done by facet fusion, and in the exposed area, it's easy. We identify it anatomically. In unexposed area, facets are identified C-arm, and through the portals by submuscular channels, we identify those facets on C-arm and we burn it, we bury it. Then bone marrow is harvested from posterior iliac crest and mixed with artificial bone graft, and that is used to ensure fusion. It is overlaid over the exposed area posteriorly. In unexposed area, it is placed in subcutaneous muscular layer and also in the areas of facet budding. Now, what is the significance of facet fusion? Facet is like the latch of a door of a motion, spinal motion segment. And if you have if you have only the small latch, the entire door is fixed. Similarly, if you can fuse the facet, the entire motion segment is fused. So you don't need copious amount of fusion in the intertransverse area, in the internal laminar area, or the anterior interbody. But if you can achieve the facet fusion, it does work well. So that was the first case. Herein we did that, and this is, you can see the difference in the clinical patient is the very good correction radiologically. And this is another case. It's an 11-year-old female with Lemke type 3B, and negative AIS. The thoracic curve was 64 degrees apex at D8, the lumbar curve was 38 degrees apex at L2, L3 disc space. So, as combining all the cases, the total cases were 5, all females, average age was 12.3. There was two syndromic and three AIS case. Operative time average was 5 hours 20 minutes. Blood loss was 213 ml. The pain score was 2.1 at 48 hours, so the pain is extremely less. Blood transfusion was 1.3 adult units per cells. And coming to the intraoperative technique, there are not much of a intraoperative technical difficulty. Perioperative complication, there was one case of pneumothorax and one case of postoperative neurological deterioration. There was no case of postoperative neurological deterioration. And coming to postoperative complication, no postoperative infection, wound healing problems, no implant failure. So, but there was one case of permanent implant at the cranial line. So disadvantage of this technique. So there was inadequate exposure. The placing screws at other levels than planned increases the size of the incision. The screw limited to the areas of skin exposure and may miss the most logical screw insertion site. Soft tissue damage may be incurred due to excessive retraction due to limited size of skin portals. Limited exposure leads to augmented view of scoliosis morphology. You don't get a global view that is obtained in the usual exposures. So you can use CM, but they are spot on views, so you don't get a global picture of the curve correction. Advantage is obviously there's less bleeding, can be operated in a less equipped hospital, does not require massive blood transfusion. It leads to less post-operative pain and hence early recovery. And preservation of spinal process has got dual role in helping in reattachment of paraspinal muscles and it helps in decreasing the prominences of spinal implants. Long term, we don't know what will be the long term fusion. Will there be any implant failure? But as per literature, there's no defenses long term. So in conclusion, we can say that this is a very good procedure, and we are further studying this process, and we are trying to convert, do more cases in this technique, and we will come with further data. But the significance of our study was that the certain things, the certain modifications, like using non-connected uh, simple reduction screws, can help us in doing this technique. Thank you.